It's my honor and my pride to present my dear colleague and younger brother, our genius, Dr.Al Husein Ahmed, a lecturer of pediatric cardiology, Cairo University. He will be talking about the Cairo University Specialized Children's Hospital experience in conduction system pacing.
السلام عليكم. مساء الخير الأول. إن شاء الله I will make it very short. This is actually our specialized hospital experience in conduction system pacing. We will talk firstly about pacing in pediatric population. Pacing in children is mainly performed as a setup of congenital or post-surgical complete heart block, and less frequently in pediatric populations that we pace for sinus node dysfunction. The indication, anatomical variation, and technical skills required for pacing a child, although it seems simple, but it is more complex than it seems and actually requires special skills than adults. In children weighing less than 15 kilograms, our approach was a single chamber RV epical pacing in VVIR mode. In majority of cases, this pacing mode has low threshold for the lead, good R-wave sensing, and long battery longevity. And in this mode, the operator just insert one lead in the subclavian vein, avoiding any complication and future venous thrombosis or venous obstruction, allowing for further upgrade later on in life. What are the pros and cons for this problem, for this pacing mode? Actually, it's technically easier, shorter fluoroscopy time, lower incidence of venous obstruction, and let's face it, single chamber pulse generators are smaller. And they avoid the need, of course, for epicardial pacing. But however, we have the problem of the synchronous pacing, especially if the lead was fixed in the lateral wall or in the RVOT, loss of atrial synchronous pacing with the ventricle, so we have an interventricular and an atrioventricular dysynchrony, and patient with high RV epical pacing burden, and actually a lot of our patients has this problem, are at higher risk for developing pacemaker-mediated cardiomyopathy. Actually, in this paper with permanent pacing in children, actually they found out that although some of these patients develop decrease in the ejection fraction, however, their symptoms are not that severe. Actually, they all pass without significant symptoms. But our dilemma is children who develop early onset significant dysynchrony with New York class 2 or 3, actually symptomatic patients, significant symptomatic patients, patients with structural abnormalities requiring synchronous atrial and ventricular contractions, like patients with obstruction in their LVOT, patients with cardiomyopathy, and the patients, our main issue here with patients with high burden of RV pacing. Epicardial pacing gives us a partial answer for this question, which is epicardial dual pacing mode. But however, it's a surgery with a sternotomy or thoracotomy in a very young child. There are usually higher threshold and impedances causes excessive battery drainage and requiring early and frequent replacements. Batteries, because they are child, they play a lot. Batteries are more liable for exposure, infection, and malfunction. So part of it is answered and the other remains. Patients with high burden and children who develop early onset significant dysynchrony. Actually, in the 2023 HRS guideline for cardiac physiological pacing for the avoidance as well as management of heart failure, they answered this part of the question. Actually, our patients usually run in the blue line, in the yellow line. Is the patient with indication for pacemaker therapy, and the ejection fractions between 36 and 50. So we have a high benefit then risk for conduction system pacing or left bundle branch area pacing. And as our colleagues and my colleagues said before, CRT with biventricular pacing in young children usually will end up with an epicardial pacing rather than an endocardial. So if you have an endocardial approach, it is way better than the epicardial approach. From here started our journey. In the workshop immediately before the last our international conference, in collaboration with Cleveland Clinic, we implanted our first patient with left bundle branch area pacing. This was in October 2023. After that, we successfully implanted 5 cases in June 2024, and we started now to regularly implant, and now we have a total of 13 patients just in this labs area. Our patients ranged from 4.5 years old to 12 years old, and weight ranged from 12 kilograms actually to 55 kilograms. All of our patients suffered from complete heart block. Actually, our first patient was post-ablation block, but we have a congenital, we have post-operative, and we have post-ablation. 5 of these patients have received RV apical pacing with burden of ranging from 75 to 99%. Regarding symptoms, unfortunately, 80 out of our 13 cases reported dyspnea on moderate exertion, and only 2 cases received diuretics and ACE inhibitors. Our patient unfortunately had a left bundle branch block morphology with QRS ranging from 120 to 180 milliseconds. Non-paced patients, although showing a relatively narrow complex, but some of them suprahesion escape rhythms ranged up to 110 milliseconds. They show significant dyssynchrony by echocardiography. Actually, these are some of the ugly speckled tracking series that we had. Actually, one of the patients have significant septal to lateral delay of 300 milliseconds. Okay, this is how much the septum activates very early, and the lateral wall of the left ventricle lags 300 milliseconds before, okay, prior to contractions. From this arrows is the yellow and the red, the green arrow, sorry, the yellow and the red arrow. All of them have some sort of dyssynchrony in the anterior region, on the septal region, or actually in the inferior region. This is an echocardiography of one of the patients. Actually, this is our first implant. We implanted dual chamber pacing for around 12 out of these 13 patients. Only one case, we had a very small vein, so we decided to implant a left bundle branch area lead, only without an atrial lead. Those patients showed an average QRS of duration of 85 to 95 milliseconds after the implantation, with peak left ventricular activation time of around 55 to 80 milliseconds. Threshold ranged actually from 0.5 up to 1.2 volt, and the impedances ranged from 580 to 1,200 ohms, but I need to say that this patient showed a rapid decline in the impedance after 24 hours to 890 ohms. All our 30 patients were Medtronic Sensia with dual chamber pacing, pulse generator, and an atrial lead of 5568, and the Select Secure lead model 3830 for the left bundle branch area pacing. Actually, this is the same patient that we implanted firstly. This is how it showed a very good contractility and globular improvement. Actually, this patient, we stopped diuretics, we stopped ACE inhibitors. This patient went home without any medication. Actually, she reported no symptoms anymore. 24 hours. Actually, this is her same echo, but actually we just showing the lead right here in this 3D model. This is her lead in the septum. This is the same patient with her speckle tracking post implant, showing a remarkable improvement of all of her global longitudinal strain. Regarding the ECGs, we have a very nice narrow QRS complex. We can appreciate a pacing spike in a QR pattern in V1 with this actually QRS complex with around 80 milliseconds. This is another patient showing the same phenomena with spacing spike and then a QR pattern in a V1. So to sum up, our journey of exploring new options for synchronous pacing is in a growing heart. Each option should be critically appraised prior to implant in the regular practice. Actually, yes, left bundle branch area pacing is a good option. It has a lot of advantages, but still it is understudied. This is a very important thing. Data about retrieval and removal of the lead is still not available, whether in adult or pediatric population. And many patients might be challenging, especially post-operative tetralogy of fellow patients and patients with wide VSDs and the wide patches after operations. So you get very hard to put a lead in the left bundle branch area. Thanks.
Thank you for your very nice presentation. All of us is abroad proud of you. You are the most junior,
Yeah.
but most the best and the excellent. I think in the future you will be there.
Thank you.
Thank you.